So good afternoon and welcome to this ERKNet webinar. My name is Francesco. I'm speaking from my office here in Rome. As always, before starting, let me remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the GoToWebinar application that appears on your screen, and I will then ask the question at the end of the presentation. The webinar will last approximately 30 minutes. We will then have approximately 15 minutes available for questions. So our speaker today is Michal Malina. Michal is a pediatric nephrologist in the National Renal Complement Therapeutic Center and at the Great North Children's Hospital in Newcastle. He received his medical degree in Prague at the Second Faculty of Medicine of the Charles University. He then continued his training at the University Hospital Motol, which is also in Prague, where he also obtained his PhD degree in human physiology, and he defended his thesis on the genetics of nephrotic syndrome and atypical HUS. He then completed a research and clinical fellowship in Heidelberg and a research scholarship at the Cordelier Research Center in Paris, where he studied complements and its role in atypical HUS. When he returned to Prague, he worked as a pediatric nephrology consultant. He founded a research laboratory, and he was appointed national coordinator for the International Atypical HUS Registry in Czechia, in addition to participating in the activity of the ERKNet working group on HUS. Michal works in Newcastle since 2018 now. In addition to his clinical commitments, he is a PI for studies on complement therapies and other studies that are related to pediatric nephrology. And the title of his talk today is Enter Factor H Auto-Antibodies. Please, Michal.
Thank you very much, Francesco, for the lovely introduction. And I will go to the presentation now that, as you have heard, its focus will be on anti-factor H antibodies and their relevance to certain diseases in pediatric nephrology. So I think that I would need to start with a bit of a complement introduction on that, and mainly before we will go to factor H antibodies, to say something about factor H, because that would be the central protein that the antibodies are targeting, and all the pathophysiology that it is then ensuing with some problems from that with the presence of antibodies are linked to this protein. So factor H is quite a large soluble glycoprotein, mainly very flexible, made out of 20 complement control proteins, or sometimes called short consensus repeats or sushis, that they are arranged in a matter one after the other. It is having a lot of binding to certain parts of complement, and it is the essential control protein for alternative pathway of complement, because it with activation of C3 in the alternative pathway, it works, as you see on this picture, on various parts of inhibition. So it can prevent the binding of factor B, competing with factor B to decrease the binding to C3 and generating C3b. It works as a cofactor with factor I to increase the inactivation of active C3b on the surfaces, and then it promotes also degradation of C3b and competing with recruitment of C3bs. So all that then protects it from advancing to the late stages of complement and the terminal complement pathway, which can then be deleterious when it is overactive on the surfaces, or it creates abundance of active C3 products and pro-inflammatory products in the fluid phase. So all that is essential. Factor H is also quite interesting in a way that it is utilized by certain bacteria as a method to escape the immunity, particularly Neisseria, that can attach to it and use it as a camouflage, and same for Burkholderia and other pathogens. We will be dealing with a large group of diseases that they are linked to factor H antibodies, because we know that these are mainly on the acquired side, or on the part of large group of TMAs and proliferative glomerulonephritis. You can see on the slide that mainly where they will be having their effect is in atypical HUS, where they are responsible for triggering complement hyperactivation, or we can see them in certain glomerulonephritic diseases, mainly like the C3 and PGN, but also they have been identified in patients that they were having IgA and lupus in very small entities. So the two main diseases that are linked to factor H antibodies would be the atypical HUS, where you see some nice images of a thrombotic microangiopathy from a kidney biopsy and some peripheral features of hemolytic anemia. And on the contrast with the MPGN, where you see a proliferative on the slide of the kidney biopsy, and the main feature on immunofluorescence, abundance of the C3 deposition on the in the glomeruli on immunofluorescence. If we will define a HUS, so HUS is defined as a syndrome. That means a couple of symptoms, which in this case it's low platelets, hemolytic anemia, high LDH, negative DAT, low haptoglobin, and high reticulocytes. The targeted damage is then seen as acute kidney injury, and we know by lots of finding that it is a quite an ultra-rare disease affecting approximately 2 cases per 100,000 per year. Children about 0.26 to 0.75 cases, so mostly a half in that, depending on the cohorts. Atypical HUS is a disease of complement. I don't think that I need to reiterate it, that it is quite now known fact that the pure atypical HUS are complement-associated HUSs, which mainly arises from destruction of the endothelium when there is a hyperactivation of unregulated complement that deposits and attracts further cells that they are damaging and creating microthrombi in the microvasculature of the kidney and glomeruli, leading then to platelet consumption and hemolytic anemia and ensuing kidney injury. If we will go to the first question for the webinar, is mainly how many of you are having an access to factor H antibodies testing? Be interesting to see.
I've started a poll. And we have another 10 seconds. Francesco? I can also read out the, the results. So 74% of the attendees have access and 26 not.
Quite very good numbers, I would say, because they are one essential part of investigations when we are having a suspicion on atypical HUS in patients that they are having either recurrent HUS or where we have excluded an STEC HUS. So we are now having about a 20-year anniversary of their seminal finding in 2005. So there was a bit of a gap. We knew that there was a factor H associated with atypical HUS and pathogenic changes in the gene for factor H in large families that were identified in England in areas in Exeter. And the French group then sometime after that identified an acquired type of atypical HUS where the antibodies are mimicking the similar disease, mainly by stopping the function of factor H. So this is the seminal paper by Dragondury where they have identified 3 children in their cohort of recurrent HUS in children from 48, and they have found factor H autoantibodies in 3 children. This showed the pathophysiology of the process and the functional relevance of these antibodies, which broaden the whole scope of what we need to diagnose if we would like to ascertain that this is a complement-related atypical HUS. Do you have an idea what would be the proportion of patients that you are having in your cohorts, either personally or nationwide, with positive factor H antibodies?
I started the second poll.
And I have turned on my microphone now.
So let's wait another 10 seconds.
I think the numbers are stabilized. So Michal, so most of the audience said 5 to 10%. That is 63%. 20% choose 10 to 30%, and interestingly, 10% chose 0%. You have a 7% that opted for 30 to 50%. So by far, the 2/3 have responded that 5 to 10% is the proportion of patients with antibodies.
This question is quite interesting in a way that we are having quite a very large distribution of prevalence among the cohorts. So this is from a fairly recent paper that was putting together from those seminal 3 patients that were identified. We now know about almost 3,000 patients where we see what is the proportion. And if we will look at it, it varies quite largely from about 5% to the largest is about 60% of their cohorts. The largest proportion of factor H antibodies in the atypical HUS cohorts. There is one outlier in Czechia that we don't have a good explanation, but the largest cohort of factor H antibodies and also the largest proportion is from the India cohort. And as you see on the map, there it looks like that there might be some east to west decrease in the prevalence. If it is with different genetic background or some triggering factors is yet to be found, but definitely we see some changes in this worldwide in terms of distribution. What are the usual symptoms when the patients present? They present with atypical HUS features, so mainly HUS features that I've mentioned. There is a quite large proportion is presenting in early life, so it's more of a pediatric disease. When you can see on the left graph that it is experienced from our cohort in England, where we see that the biggest peak is between 5 to 14 years of age. And previously there was a notion that diarrhea is associated more with the typical HUS caused by STEC infections, but we can see that at least 10% and up to 30% of patients, when we compound it, are having some diarrhea at the presentation, and they are having some infection symptoms. So it's quite essential at the beginning of investigating someone who we are thinking might be having atypical HUS to rule out the STEC infection, because there is nothing like a typical presentation for STEC, or on the other hand, a typical presentation for atypical HUS. I've mentioned the factor H and its function. The factor H antibodies were studied what they are actually doing in patients with atypical HUS in the French group, where they have identified that the factor H antibodies are binding to epitopes located at the N and C termini. So the C termini would be probably most associated also with the mutations in factor H with atypical HUS, and they were inhibiting the cell protection on the surfaces, inhibiting interaction with the C3, as I said, that it was then disrupting the inactivation. So all that leads then to a hyperactivation of complement through the C3 activation and on the surfaces, and then thrombus formation and platelet consumption and ensuing HUS. We now know also that the development of factor H antibodies is linked also to some genetic changes. There are deletions in related proteins. The factor H is surrounded by several genes. The gene for factor H is surrounded by several genes for related proteins, that they are having their own pathophysiological relevance, as it looks like those patients with factor H1 deletions are more prone to developing these antibodies. There were some ideas why this might be happening, that it changes the self-recognition of factor H if these proteins are lacking. There is a fairly approach in that when they were monitoring those different types, and it looks like that if there is a disruption in the CFHR1, which is not existent, and there is an induced epitope on the factor H, most likely by an interaction with certain pathogens that can lead then to creation of neoepitope on factor H when there is no presence of factor H related proteins, and creation of antibodies. And that links quite nicely to what I have said previously, that some microbes are using factor H as a sort of escape. So it's an interlink between these three. So, and we see it in most of the HUS that to manifest HUS, you need to have either some rare pathogenic variant in complement genes, you need to have some immunological factors like factor H antibodies, and you probably need to have a trigger, and which disrupts the complement, creates a more proactivation environment, mainly with some infection, leading then to the manifestation. Now to the third question, which is how are we approaching the treatment? Because there is no specific consensus on how should we treat atypical HUS with factor H antibodies.
Open the poll.
So is this a tricky question since there is no consensus?
There is no consensus, but it is more to establish what probably different people will be doing.
And up to now, 63% have voted. Okay, so Michal, so there is a half of the audience, 49%, would use eculizumab and antibody targeting agents targeting immunosuppression, either rituximab, cyclophosphamide, and methosteroids. So the second answer for 49%. And then we have a complete split, 27% eculizumab and 24% plasma exchange and antibodies targeting immunosuppression. So 50% answer 2 and 25-25 for the other 2.
These responses can also mimic the availability of eculizumab. We know through the seminal papers on trials with eculizumab that it is a very good option for treating patients that they are having complement associated HUS, that most of the patients, more than 90%, achieve remission when they stay on the treatment, and it is having very few side effects except the increased chances of meningococci infection, so which is an excellent medication. And the issue with it is its cost and its worldwide availability, which now with the advent also of some biosimilars might be less problematic, but still it remains quite costly drug, which not everyone can have access to. So there are several options how the problem with factor H antibodies are tackled. There is a very good and the largest cohort of factor H antibodies caused atypical HUS from a cohort in India, almost reaching 800 patients, where there is shown that when the plasma exchange is started early and there is quite strong immunosuppressive regime, and we will bring the factor H antibodies titers down, the disease gets under control, the plasma exchange can be stopped, patients achieve improvement. In our experience, when we have treated patients purely with eculizumab, all of them achieved remission of the disease. However, their antibodies in some cases stayed higher, but it looks like that even without additional immunosuppression, we have seen some decrease in the factor H antibodies titer purely on eculizumab. This is yet to be studied if it is a real effect that we see some decrease in the antibodies spontaneously as the immunity of these children matures. And we definitely see some decrease in the factor H antibodies in those where there is a combination of treatment with eculizumab and other immunosuppressive drugs. So there is definitely, all these approaches are valid, mainly depending on the availability of eculizumab and on how we can get this disease under control. And if we can either monitor then the factor H antibodies, and if we will see their decrease, and we can stop them. Also, there are now two large experience with withdrawing eculizumab in patients also with factor H antibodies, one in a Dutch group, one in French group, where you can see that there is a potential of recurrence of the disease after stopping eculizumab, which is up to 30% chance. But if they will get rid of the antibodies, it's a very nice option that they will not need to stay on the treatment. So now it is to be found if we need that immunosuppressive push where we have the availability of eculizumab, or if there is only some limited time. In my experience, we had several patients that they were not having additional immunosuppression except eculizumab or ravulizumab, the second generation of eculizumab. And personally, I know at least about 3 patients when the titers dropped spontaneously and we could discontinue the treatment. So this is still a slightly open question that we will need to tackle for how long do we need to treat with eculizumab, how we should approach the titers, which titers are relevant in this disease. So this is to summarize it from the same paper from Kandeval, to seeing that the options when we have elevated factor H antibodies, the plasma exchange gets rid of the antibodies and activated products, but you need to also decrease the production, or you can have the option with eculizumab and then tapering if you will achieve control of the factor H antibodies. I'm moving to the next bit, which is also another disease that it is linked to factor H antibodies, slightly less because we see it in about only 10% of the patients with MPG and C3G, but they are most likely playing a role, and they are a slightly different type. The disease manifests as a glomerulonephritis, proteinuria, hypertension, blood in urine, and impaired kidney function and development of crescentic disease. It looks like that it is this pathophysiology. There were change in classification where we have mainly based it on the presence of the features of C3 deposition when we are now having the post-infectious glomerulonephritis, that it is self-limited, dense deposit disease previously like NPGN2, where there is large deposits and low C3, and some of them that they are having an overlap with immunocomplex and NPGN and C3. So this is a distinction, but we see in some of the patients also the presence of factor H antibodies. There were some few functional studies of the antibodies in MPG and C3G, which showed that the antibodies are doing something slightly different. they are not that much affecting the protection of the binding to the surfaces and then promoting that procoagulation and prothrombotic effect, but more it is working in the fluid phase, creating lots of immunocomplexes and pro-inflammatory molecules like C3a, C5a, and then leading to the inflammation in the kidneys and deposition of C3. So slightly different in these. So for evaluation, if you have a C3G and have a C3 dominant, we have an option to investigate either the factor H antibodies that they are the part, but there are also other markers that they are causing the complement dysregulation, which most abundant are the nephritic factors, which are most prevalent. They are most of what they are doing are stabilizing the convertases, creating more potent convertases, that then they are overactivating the complement, leading to C3 deposition and low C3 in peripheries. There is not yet a perfectly established treatment option. So the best what is from the retrospective cohorts and agreement among experts in children, if there is a decreased function, if there is a crescentic disease, and if there are any problems that could lead to end-stage renal disease, to treat with combination of tapered steroids and MMF, which reduces the inflammation, gets it under control. The outcome is not great. We are dealing again with very rare disease, even probably rarer in terms than atypical HUS. So gathering all the data for good outcome is essentially usually through large collaborations. And with that, only about 50% can have a good response. Those that have a good response, as we have shown in the cohort of C3Gs in England, usually don't have a very bad prognosis. Those that are having problems from the beginning usually are having worse prognosis. And we would like to look for something new in these. And it looks like that there is a development for further new medicines. They are now tested in adolescents and also in adults. They have reported. We are having a program of C5 blockade with eculizumab in C3G in very active disease with transplanted patients, but it looks like that it decreases the inflammation. It prolongs some vintage for the transplant, that it can survive longer, but it is not great. So we will need to look somewhere upwards in the pathophysiology to the C3 activation. So the new and now the two most prominent drugs that they are working, it looks like that they are working on the right spot, is pegcetacoplan, which is blocking the C3, and iptacopan, which is having a great advantage that it is an oral small molecule that blocks factor B and creation of C3 convertase. With the iptacopan, the adult study showed a very good outcome. So we hope that this medicine will also be available. Now it is in a process of a trial for adolescents and patients over 12. We'll see how it will report, but the adult patients are definitely showing a good outcome with this medicine and very good safety profile. So that's probably something for the future. I would like to thank you for coming to the webinar, and I would like to send greetings from our complement therapeutics team in Newcastle. And if anyone would have any questions, I would be happy to ask them, to answer them.
Well, Michal, thank you very much for this very interesting webinar. I think that you very nicely summarized all the data that has been collected over the past 20 years. Before we move to the questions, maybe let me just read to you, and you can read it yourself, the next webinars. We will have a webinar on TTP on September 9, another one on membranous nephropathy the week after on September 16, and a last webinar in September on phosphate disorders at the end of September, and you can read here the speakers. So now we can move to the questions. And again, thank you so much, Michal, and we already received quite a few questions. So, so there's a first question by Adrian Lungo, who was wondering whether the differences in prevalence of anti-factor H antibodies was related to the difference in CFHR1/3 gene deletions, or because there were more infection in some parts of the world.
It looks like that it is possibilities are both. We see that in MPGN they are creating the antibodies even when they are not having the deletions. So there is probably a different process in terms of the atypical HUS ones that they are targeting the end parts of the factor H. It is likely that there would be some effect of infections. We have not yet found the possible infection that might be doing it, but the culprits could be some of the bacteria of that they are using, as I've mentioned, the factor H as their shield against complement activation and immunity bypassing.
Okay, and then a very important question here is Happy Sawiris, and apologies to everybody if I don't pronounce your names well. The question is, what is the cutoff level of anti-factor H antibodies to make the diagnosis? What is the best management approach for those patients that have a residual moderate to heavy proteinuria after treating of this disease, even when the antibody has returned back to normal?
There's it looks like that the cutoff, mainly what was seen in the cohort from India, is when they are over 1,000. First thing, they need to be normalized. So the international consensus is mainly that the normalization is based on the samples from France, that they are then equalized to the same number of reporting units. So if these units are over 1,000, that it mainly says that it is very likely that they will be causing the pathophysiological process of complement blockage. Then it depends on the type. There is a possibility for identifying certain parts of them, mainly the epitope mapping, where the antibody will be affecting. So sometimes there can be antibodies that they are probably less potent because it's a polyclonal antibody mix. The other thing would be the question that you have asked about the residual proteinuria. We see patients that are having atypical HUS. We had recently 2 cases that they were having factor H antibodies, usually in quite high titer, and they were having proteinuria. They were biopsied and they were having an overlapping feature of MPGN. And even when they were on eculizumab, this part was not, mainly like with the C3Gs, was not completely blocked by the C5 blockade. So they required either decreasing the titer of antibodies and additional immunosuppression. For those, if the antibodies would be in lower titer, we see that with the titer under 100, that it is quite unlikely that it will be causing any problems. If there is residual damage from AKI, it would be an approach like with any other patient that was having some previous AKI and residual damage caused by not complete reparation. That means ACE inhibitors. Maybe in the future, for in adolescents, it's probably a possibility to use flozins or other antiproteinuric drugs if they will be coming more to lower age groups.
Okay, we're getting more and more questions, so some of them are very lengthy. Just saying that Adrian Lungu was actually mentioned that he has 6 patients treated only with eculizumab, and he was simply here sort of publicizing this his experience and saying that maybe other experiences with monotherapy with eculizumab should be put together to see to analyze them. Then we have a question from Manuel Vaquero, which has been much debated lately. But before asking you the question, can we say, Michal, that the titers of anti-factor H antibody is really dependent on the laboratory that is assessing them? Because this is my experience. So depending on the type of laboratory, you will probably have threshold for pathogenicity and normalities which are different. Would you agree with that?
It's very possible, but I know that there is an international collaboration definitely between our UK group, German group, Italian group, Spanish and Indian, that is trying to report the normalization based on the original samples from Paris mainly. That it creates sort of at least availability to compare the cohorts, which is always a normalization, because it's an ELISA test for the factor H antibodies, so it can have different results. So the only way how to standardize it is to use a sample that it was previously standardized as a control and then equalize one's samples to it.
Absolutely, and I think, honestly, I personally think that this is a very important work that is much needed. So Manuel Vaquero is asking you, what is your opinion on anti-factor H antibodies in post-infectious glomerulonephritis? This has been much debated lately, and he complements this question by asking you, are they a reaction to complement activation? Do they carry a risk of recurrence?
I think that the experience is yet to be found in that. I think that there could be, because at the beginning, we are not starting from the pathophysiological findings in these patients. We start with a child that is having hematuria and proteinuria, and they might have had, which is quite common, having a throat infection with streptococci or other infections. And usually the approach is we go with the more common things, and we expect that it would be more possible to be common that there is a post-infectious type of glomerulonephritis. So we will not try to be very aggressive at the beginning, and we would probably not investigate it at the beginning. We would then, if the child is progressing with proteinuria or hematuria, we would most likely do a biopsy trying to identify it, and then it would largely depend on very skilled pathologist and then further follow-up of the patient, because we see that some of those that they were in our cohorts of C3G were showing very favorable outcome, even without any immunosuppression. Some of them, I don't think that all of them were having their factor H antibodies measured. The other thing, there could be factor H antibodies as the immunity matures in the children that might not have the consequence. So then it is, to really cut it out would require some long-term follow-up between these cohorts to delineate if there are any specific sub-cohorts of these patients.
But can I push you? Do you think that anti-factor H antibodies are related to post-infectious GN? That was the question.
Personally, I think that there might be a link, but I don't have complete evidence that I could put on the table. So if I would see someone who is having a glomerulonephritis, or if there would be a hint of TMA and there would be positive antibodies, I would be more prone to complement.
Post-infectious. And for the audience, the question arises from a report from the French group a few years back in JASON, I think. Where they report a higher prevalence of anti-factor H antibodies in a cohort of post-infectious patients. Correct me if I'm wrong, but this was, I think, the reason. Now, we have a question now that I haven't read because it's a huge question by Sebastian Batz. Look, I'm going to try to read it, but it's nearly half a page. So please.
Or is there any that someone would like to utilize expertise of our center? I will get back if someone would like to send me an email. I'm very happy.
This is a very good idea, but still, since we have time, let me try to read it to you, okay? How do you assess the role of B-cell target therapy in eliminated factor H antibodies. Should eculizumab be discontinued earlier following rituximab administration, or is a prolonged combination therapy advisable? Which criteria would you consider when evaluating the extension of the eculizumab dosing intervals? Why don't we just stop here and try to, so the first one is, how do you see if it works? You have eculizumab and you have rituximab.
So eculizumab and rituximab should not interfere each other. That we think that it should be safe for concomitant treatment. In terms of interval prolongation, we are not much advocating for that, especially now with the good outcome in the stopping trials, in the discontinuation of eculizumab trials, that where we see that if we are having patients even with some titer or factor H antibodies, they might be at risk of relapse, but not all of them. We have withdrawn almost 40 patients from eculizumab, including factor H antibodies, and it looks like that not much was happening in some of these patients, even with higher titers. So that's one answer. So more than prolonging intervals and measuring activation of complement, which is extremely tricky, we would be more for limited time on eculizumab, fairly with early withdrawal, with very careful monitoring for relapse, which looks like, in our experience, where we will be shortly publishing the results of our trial of stopping patients from eculizumab, that it looks like a safe option if we will have a good follow-up of these patients and good monitoring. So that was one question, and the other, for the monitoring, the Indian cohort is showing that with their plasma exchange and immunosuppression, when you will suppress under that let's say threshold of 1,000 units, then they are withdrawing the plasma exchange and reducing the amount of immunosuppression. The rituximab should be working mainly on the B cells until they recover. So in that, it's mainly, if you will go with the either with the titer of the antibodies, but it might not be relevant. It is more the response. So then it is to stop the eculizumab if we are thinking about that, and then very carefully monitor for potential relapse and be available for restart.
Okay, so actually the question was much shorter than I thought. It's just that the same text was repeated many times. I think you answered this. I think if I interpret the question is that to have a clear indication, you start eculizumab to block the process. You give rituximab. When do you stop eculizumab? Once you have seen the antibody goes down, and then you leave only the patients on rituximab? Is the sequence that
it is not a thing that we are doing actually. So we mainly do an eculizumab monotherapy in all our patients.
Okay.
So all of them are coming on eculizumab, and then we monitor every 6 months their titers of antibodies. If they drop to an insignificant level, we stop the eculizumab. But it is likely with the results of the trial of stopping and the French experience with stopping eculizumab, we might be after 6 months stopping much larger proportion of these patients.
And can I just follow up on this? In your presentation, you were mentioning the idea of, in addition to eculizumab, to give treatment to decrease the production of antibodies. What do you do?
So we are not doing anything actually. We are really, we have decided that the additional immunosuppression with its side effects, be it B cell depletion by rituximab and then risk of viral infections, being it steroids with their side effects in age group of between 4 and 10, or the least probably toxic with side effects would be the MMF. But we have mostly decided, with the good availability of eculizumab in our center, very targeted for those patients that they are truly having complement activation, that we opted for monotherapy and careful monitoring with the possibility later of stopping eculizumab. And we see that some of them are dropping it eventually, even without additional immunosuppression. It yet to be confirmed that it is true, but we have withdrawn several patients only that were on monotherapy of eculizumab.
Very interesting, very interesting. So another question that I also had in mind is asked by Marius Maglinas, and he's asking which age group is affected most by anti-factor H related HUS. So let me complete this question. So if you compare anti-factor H related HUS and genetic forms of HUS, what is the age difference?
I would say that it is more spread for the genetic ones. I can pull it out with a picture, but we really see that the largest proportion is between those 4 to 10. The factor H genetically caused are more early usually that we see, and the CD46s, factor I, C3s are scattered more throughout, with a second peak. The peak is still somewhere in childhood, but the second peak is also around pregnancy time, when in women between 20 and 40.
Okay. Now another question by Anu Kaskinen. I suspect you sort of answered this indirectly previously, yes, he actually thank you for the great presentation, and I think this is a comment that I've seen several times in the questions. How would you manage a relapse of anti-factor H antibodies associated HUS in a patient on maintenance immunosuppression with MMF? Would you start eculizumab and steroid, or consider something else?
Again, it would be center variable, but if there is a relapse with significant titer of factor H antibodies, regardless of the MMF, he would most likely start on eculizumab. And then because the patient was withdrawn previously from eculizumab, possibly, or achieved it through plasma exchange, then it would be then individualized based on the specific case. But I think if I would see a relapse, like really HUS with all the features, the treatment would be eculizumab, at least if it is available.
So Lika Tersteeg is asking you a question based on her personal experience. She is curious if you in Newcastle can determine if the factor H antibodies are allocated to are directed towards the C or the N terminal, and thereby functional irrelevance, because they have a couple of patients with recurrent HUS with low titers of factor H, antibodies less than 1,000, and even one patient had a relapse when titers were decreased to about 250 with the immunosuppression. Could it be that these antibodies are highly potent? How can they research this more properly?
There is a possibility. In Newcastle we do epitope mapping. Also, I think that the group in Hungary also does epitope mapping, where you can map which parts of the 20 domains the antibodies are targeted to. I don't think that there is specifically the avidity measurement. I would need to double check how strongly they bind, but we definitely could map them to specific regions of factor H. So that is a possibility. The other thing, I have not mentioned it in the talk, but even in our cohort of 17 patients with factor H antibodies, I think it was around 30%, I think it was 7 patients, was having concomitant other genetic changes. This was also reported from the Indian cohort, that patients with factor H antibodies were having concomitant other complement-associated pathogenic mutations, factor H, factor I, MCP. So definitely would be worth in a patient that was diagnosed with factor H antibodies and didn't have a complete genetic workup to have a genetic workup for that. And if there would be we can offer help with the epitope mapping actually in some of these patients.
Okay, so Marius Miglinas also asks you, what is the exact role of homozygous FHR1 deletions, because it's common also in the healthy population?
It is identified in it would be different population by up to I think 20% are carrying the deletion, and there is, I have showed in the presentation that the deletion makes you more prone to developing the antibodies against factor H, probably by this neoepitope forming by induction by the bacteria or some other antigen that binds the factor H, and then it is recognized by the antigen presenting cells. So it is likely that there is a risk, but inherently, if you are purely having factor H related 1 or 3 deletion or others, it doesn't look like that it is a factor that would be in its own causing you some problems. Therefore, we don't, if we have patients with factor H antibodies and we have not identified any other genetic changes, and we have identified their deletions in factor H related proteins, we don't screen the family or anything. We don't think that this is that purely that factor is not enough to cause like an additional risk. It is an additional risk for developing the antibodies probably, but you need much more steps to reach that.
Absolutely, and thank you for this, because I think it's a very important question. So not all patients that have the deletion will eventually develop the antibodies.
Yes.
As you said, because it's important to remember this. Now, to finish, I just want to give an answer to Bianca Caban, who is asking whether we will cover typical HUS and involvement of complement system. And I believe there will be webinars that are planned in the next 2 years that will cover this topic. And then I have a question for you, and that is the question. So we do have some patients that are doing fine, but they remain with high titers. So we don't see any change in the titer, and actually these titers tend to fluctuate also a little bit over time. It's not that they're always straight, but they have clearly titers above 1,000, even 3,000, 5,000, 10,000. Would you stop eculizumab in these patients if they're doing well, even though the titers are very elevated?
Going with the experience, I think that they wouldn't be the first ones. If we have our large cohort, we know those ones that they are having no mutations or factor H antibodies, virtually no chance of recurrence of HUS. So those will be the first that we will be stopping, followed by probably by the MCP that can even go into remission spontaneously. Those with factor H antibodies and in high titers, it would need to be discussed with the patient. The risk from the previous historical cohorts is up to 50% of relapse at some point. So that would be, because there is an inherent risk also from eculizumab treatment with the meningococcal infection. So then it will be the balance for each patient. But probably we will try, because the Dutch experience shows that even those with higher titers are not relapsing, all of them. So, but we are not forced to stop. Like for example, in somewhere where there is mandated stop for eculizumab at certain time. But this data would need to be collected if we will stop it to get the answer. How many, and from those that we have stopped, will relapse? And if they relapse, does it cause them harm? Because we are expecting that some patients will relapse. And if they will relapse, we will restart them without causing harm, and we will need to keep them on eculizumab.
Yeah, I mean, this is clear. I just wanted to push you further. And I say, you have a patient, he's on eculizumab since 2 years. You mentioned that you have data that you will publish. He still has a titer of 5,000. He's doing perfectly well. It's 3 years that he's been on eculizumab. Would you try to stop it?
Personally, probably not.
Okay.
If I wouldn't be forced, I probably wouldn't. I would probably keep it and see how the titers are doing, because in my experience, lots of them are improving titers.
Okay, but this is the question that I really wanted, because these patients actually occur, they exist. You have these patients that have, and I think your answer is actually very useful because of your large experience. And I think it was a wonderful presentation. I think we also had a very animated question time, and we're coming to the end of this very nice webinar. So Michal, thank you so much. I think we all learned from your experience. And the next webinars will be after the summer break. So see you all in September. Thank you.
It was a pleasure. Thank you very much.
Thank you.
Thank you, and have a nice afternoon. Bye-bye.
Bye.